Hi everybody, welcome back to my channel, and if you are new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today our guest is Duc Nguyen, physical therapist, and he is going to talk about assessment and treatment of extremities using the McKenzie method. Duc graduated in 2009 and became Diploma in MDT in 2016 and works in a certified McKenzie clinic. I hope you enjoyed the show. Hi Duc, how are you today?
Good.
Welcome to PT Pro Talk.
Thank you. Thanks for having me.
So we are going to talk about extremities today, so I'm excited to dive deeper into that. So let's jump right in. So could you tell us a little bit about yourself, your career, and how did you get to where you are right now?
Sure. So I'm from Montreal, born and raised. I went to McGill University for my PT, graduated in 2009. And for the first 2 years of my career, I've worked in a private clinic as a manual therapist. And frankly, I wasn't sure if PT was right for me at that point. You know, I remember walking out to the parking lot and thinking, man, I wonder if I should become an accountant or something, or an architect, because I wasn't sure I wanted to do this for 30 years. I didn't feel like it was super effective. I was telling a lot of my patients that, yeah, it's normal, that it takes time for it to improve. And so fortunately, all that changed when I took my Part A, a few months later after that. And of course, I had Colin Davies. So he rocked my world and made me realize that people get better a lot faster than I thought was possible. And so from then on, I went all in into this McKenzie system and took Part A, B, C, D within a 2-year time frame. Decided after my Part C, Part D or something that I wanted to do the diploma program. So I got certified in 2013, enrolled in the diploma program in 2014, and graduated from that program in 2016. So ever since then, I've been working in the private clinic my whole career. And what's nice about the diploma program is for sure you get a lot of theoretical knowledge. You get a lot of practical tips as well while you're on your clinical, and you become a whole lot more efficient as a therapist, an MDT therapist to classify. But I think what's helped me a lot was it has given me the ability to self-assess myself and self-correct, so that after the diploma program, I have continued to remarkably improve, I find. So yeah, if you're considering it, Mariana, then I highly recommend. So working in a certified McKenzie clinic around a bunch of like-minded clinicians has really been helpful, I think, which I didn't have at the beginning of my career.
That's awesome.
Yeah.
And you jump really quick to the diploma program, so I'm jealous of you.
Oh no!
Yeah.
I wish I did it earlier,
awesome.
But yeah.
But that's awesome. So let's go ahead and talk about the extremities. Mm-hmm. So what are the most common extremities you treat, and what is the most common classification you see on your practice?
Well, if we start out with just how many spine to extremities I see it, I think the last time I checked, it was about 45% spine, 55% extremities, or at least they come in, thinking in an extremity. And so out of those, I'd say I see mostly shoulders and knees, not out of choice. It's just what comes through the clinic. But I also get a fair bit of elbows, wrists, hips, and ankles as well. So I think I get a good mixed bag of all these extremities. So it helps me to be well-rounded.
Great. And what percentage of extremities derangements you see coming from the spine? And how do patients react to the idea of treating a spine versus extremity, that it is what they think is the, where is the problem, right?
Right. So the percentage, I haven't kept tabs on the percentage of extremity problems that originate from the spine. But I mean, we have the XPOS study for that. I don't know if you're aware of it. It is joint dependent. So typically, the further you move away, the more distal you are from the spine, the chances of it decreases of it being a spinal problem, typically speaking. But yeah, I haven't had a lot of problems with that, to be honest. I think it's the way you present the information. So I would go through my history, and depending on what they tell me, I might tell them right there that, look, let's say someone complains of knee pain, for example, and you're realizing it's, anterior, posterior, medial, lateral, bit of tingling here and there. I think depending on how adamant they are about that being their knee, or if they start to tell me, oh, I don't know what's going on, then I'll tell them, look, there's a possibility that this pain, sure, it's maybe coming from your knee, but there's another source that could be your back. And some people may be aware of it, some people may not, and it depends. I think if I present it like that and I tell them, look, we're for sure going to take a look at your knee, okay, but in order to be thorough, we're also going to take a look at your back, if that's okay with you. And 99% of people would say, yeah, sure. I make sure I tell them, look, it's only going to take 5 minutes, 10 minutes tops, and we're going to make sure that we're not missing anything. I don't have much resistance with that. I think you start off telling them that, oh, you know what, it could be your back, and you don't give them the second option of, oh, this could be your knee as well. Then they go, well, I don't think so. Rightfully so, because I don't have any back pain. But I also make sure I tell them, yeah, this could also be your back, despite the fact that you do not have any back pain right now.
Yeah, I think it has a lot to do with the way that we communicate with the patient and
Sure.
put all the options on the table, right?
Mm-hmm.
And then go from there.
Yeah.
And so let's talk a little bit about dysfunction now, that I think it's most challenging for good part of the therapies, I would say, just because the arrangements are quick and easier to treat, and we see the results, and dysfunctions, that it's a more long-term treatment. So how do you commonly start the treatment, and do you have any insights or tips to our listeners that don't have a lot of experience with this classification?
Before you even go to treating it, there could be a lot of difficulties with treating that classification because people are not identifying it correctly. You got to make sure this is actually contractile dysfunction before you remodel it, right? So if you're going through the system and let's start from the history then. Okay, if this is a contractile dysfunction, what do you expect to hear? You're gonna, if you start from the top part of the form where you would start with your body diagram, you wouldn't expect there to be, you expect local pain is what I'm saying. You wouldn't expect there to be pain the whole leg, whole thigh and calf, and you wouldn't expect upper arm and forearm pain. You wouldn't expect any tingling. You wouldn't expect it. You wouldn't expect it, although it's possible for it to be bilateral. So you got your first clue there. Then afterwards, in the you're expecting some kind of a overloading mechanism to have occurred. Just contractile dysfunctions don't just pop up out of nowhere. Now, there may be a difference between, you knowing that and the patient actually remembering that they, overloaded it the day before or something. They might feel like it has occurred for no apparent reason, when in reality, I get this fairly often, that people who train a fair bit, 3-4 times a week, then they take a month or 2 off, then they go back resuming the same exercise they did 2-3 months ago, and they're wondering why they hurt, because they don't necessarily know that your body adapts to its imposed demands. And as you train, you get stronger, sure, but as you stop training, you also get, I don't know if I would like to say weaker, but yeah, in a sense, your body adapts and grows and hypertrophies, and then it also atrophies as you do less. And they don't necessarily feel that 2-3 months later that they've lost much physical fitness. So they go back and do exactly the same weights as they did before, and then they develop a contractile dysfunction. So I make it a point to ask them, and they tell me, no, this kind of happened for no reason. Okay, so did you, if you trained, did you stop within the last, if they said it's been 3 months, then so 4 months, 5 months before, did you stop for an extended period of time? I think you could get valuable insight from that question. And then you move down in the form, and you start to realize what they're telling you as aggravating factors. Aggravating factors are activities that would load the tendon or the contractile dysfunction, right? They wouldn't just sit there and have it start to be painful. That'd be odd, unless they did a lot of exercise and then they sit after, and then it might be painful at rest for a little bit. That happens, but you wouldn't expect them to just sit there and have it start for no reason. Then you move towards your objective examination. You take a look at their range of motion. If it's contractile dysfunction, you're not expecting much loss there. It would be no loss to minimal loss, and minimal only because you're compressing that whatever affected tissue you're compressing or stretching it. And so the pain that they feel with that, I also make a point to ask them, once I get to the manual muscle testing, let's say it's a shoulder, and we reproduce pain with abduction, for example, resisted abduction, then I would ask them, so the pain I'm producing here with this, which one's worse, this one or the one that you feel when I take you to end range flexion, for example? And typically, if it's contractile dysfunction, they would tell you the one where I'm pushing against you. So you paint that whole picture, and then you go, well, local pain only hurts when you load it. There has been an overloading mechanism, no range of motion loss, strength weak and painful. It starts to sound like a contractile dysfunction, So you take that all into consideration, and for sure, it could always be, let's say if it were a shoulder, an upper extremity, then it could also be spine, right? So you check you do your spine screening, repeated movements, but if that's all good and pain-free, what I started doing more lately is that I know you're always trying to rule out derangement, right? Whether it be spinal or extremity. But if I get to that point and with that patient, let's say that I just described, and I've gone through the spine screening, which takes, again, 5-10 minutes, I've started to try to remodel them right away. I know you're doing it by the book. You're going to do repeated movements of the shoulder, for example. We're talking about a shoulder. But I found it to because the thing is with contractile dysfunctions is that if you do repeated movements with them, you may get some minor changes. Sometimes some even derangement-like changes within the session. But those changes don't hold up, and you don't And you can't know that on the first day because it looks great, right? But when they go home 2 hours later, it's the same presentation. When they're going to come back and see you in 2 or 3 days, they'll tell you it's about the same. So I've been trying to do this where I try to I classify and identify the contractile dysfunctions day 1, day 2, and for now it hasn't come back and bite me yet. But if it does, well, I just go back to trying to do repeated movements of the extremity to see if I've missed a derangement. You know what I mean? But with that kind of presentation, that it sounds like contractile dysfunction. Does that make sense?
Yeah, absolutely. And so the next question that I had to you about the contractile dysfunction. So how long usually takes to see some kind of results or improvement?
Yeah.
Usually in average with your patients.
Right. This is, I first heard it from, I believe it was Mark Miller, and he expects contractile dysfunctions to be 20 to 30% better if you're loading it correctly within 2 to 3 weeks. Now, it may not continue to get better at that rate afterwards, but you should see some kind of change, you know? And I found that to be true. If you give them the correct loading strategy for remodeling strategy, then 2 or 3 weeks later, they will see a difference. Not a major difference, but difference nonetheless, and enough for you to go, okay, we're moving this correctly. Are we just, do we need to load it up more? And at that point, I would just give them a remodeling program, a progressive remodeling program.
Yeah, and do you find any resistance on your patients to why would they do some movement that would cause them pain? Like, do they understand the process? Do you have any problem with that? With make them consistently repeat the exercise, believe in you that it's
Right.
gonna have a change, that it's gonna be small, and sometimes they don't see it or it's not significant, to keep them motivated to keep doing the exercises?
I think once again, I don't. I may have had resistance earlier on when I started using the system, but if you frame it correctly and you tell them, look, this is the kind of problem it is, it is a problem that you need to strengthen for it to get better. And so I can't do that for you. You got to do that to yourself. And how do you convince them to do something that hurts? Well, I usually start telling them that, well, look, you injured whatever part of your body that is affected, and what we need to do now is that it's healed, it's scarred up. You know, everyone understands that, and when you start pulling on that scar, it's whenever you pull on that scar, it hurts because it hasn't that scar doesn't have the same properties as the normal structures that are around it. So yeah, whenever you pull it, it hurts. When you pull it too much, it may hurt and linger. But the way we fix this problem is that we gotta get that scar tissue to be moving better. You know, you gotta put this thing under load to force your body to adapt. And it's not gonna be an enjoyable process, but you know, the goal is that this movement or this joint becomes more functional for you. So I haven't had a lot of resistance with regards to producing pain with a home exercise program. Now, you want to make sure that you give them precautions, right? And the two main precautions is that you don't want them to have pain that is progressively worse the more they do it day after day. And you also don't want them to have any morning stiffness or pain that is more than usual, because it would mean that you're starting this inflammatory process, and it means that whatever you did the day before was overloading the tissue. So I give them those precautions. You know, we do have to make it hurt. We don't have to make it hurt a ton, but we do have to make this exercise fairly uncomfortable so that it adapts. But you watch out for these two things, and And if that happens, then you stop for a day or two, you start again, but with a lesser intensity, right?
Yeah, it makes sense. And I think that if the patients understand the process, and it should be easier for them to participate, and then hopefully soon, in a couple of weeks, see some results.
Right.
And I'm curious to ask you about the progression of the loads. So we know that isometric is very common. Everybody knows how to do it, concentric and progress load. And then like when you go to eccentric and then you need to progress, if the patient, for example, is very chronic, just feels pain after like running on the anterior tibialis, for example, and then you can find any resistant movement that provokes pain, and then you believe that's a contractile dysfunction. So how do you progress on these cases that you need a lot of load? So that's just a recent patient that I had that it's just in my mind. So I was just thinking, like in this example, in other cases that we need a lot of load, eccentric load to find the pain. So how do you progress that? Like how do you what is your rationale there? And when it's not very common places, that is not like very well known, like your heel or your elbow, shoulder, like some different areas. So how do you progress that?
So I mean, if you can't produce it in the clinic, then even if you try, I don't know, your eccentric, you do your toe lifts with body weight, single stance toe lifts with body weight, and you add some weights to it, and you still can't reproduce it. It's maybe because you need to have that person, let's say it's with running, right, that they would get their pain. Maybe that needs to be their remodeling program, because you simply can't reproduce the symptoms any other way. So I mean, I would try to get them started on a remodeling program that you can quantify a little better. But if you really can't do that, and it's after 20, 30 minutes of running, and that's the only time that they would feel it, and in their daily activities they'd be totally fine, then maybe it's because they need to do that activity and progressively. Let's say it starts at 20, 30 minutes, okay, and they finish their run, they come back home, it doesn't hurt anymore, and the next day they're not worse. Well, maybe you got to keep doing that, and progressively you start, if it's 20, 30 minutes, and you start to add, either a few minutes at a time, and up till the point where there's going to be a limit, right? And the limit is pretty much when the next morning you're sore and painful, swollen. Maybe if that's the case, then you know where the limit is right now, and you just got to start where that reaction doesn't happen, and slowly work your way up. So in that particular case, I think that's what I would do. I don't. If you're telling me you can't really reproduce it any other way, I might give it a try anyways with weight bearing toe lifts on one leg, and maybe putting a backpack on with 20, 30 pounds. But if that has no effect on their pain when they're running, then it's maybe because it's the wrong loading strategy.
Yeah, no, that makes a lot of sense. I haven't thought about using the activity itself to remodel it. Yeah.
But it's because people, the contractile dysfunctions and even some derangement, if they keep active, some people can self-reduce and self-remodel, and they may not get it to 100%, but if they keep active, then that tissue is going to remodel itself to a certain point. And so, they haven't necessarily given it an exercise protocol, a progressive remodeling exercise program to do that. They just continue to do their physical activity, and so it's a question of loading, right?
Yeah, no, that makes totally sense. And what do you think about the eccentric movements with load. So if you need, how do you progress? So do you start, for example, in that case, the example that I gave you, I thought about doing the normal movements, without gravity, sitting, doing the resistance movement with the bands, inversion, dorsiflexion, and then trying to resist them to get the eccentric. So if that doesn't work, so how do you progress? Like, what is your rationale on trying to progress the load on eccentric movements?
I think you're right in a sense that it's like a level system where the isometrics is at the bottom, and you start adding load to it, whether it be concentric or eccentric. But then people shouldn't forget that there's plyometrics, right? And so if you've gotten to the point where you've done concentric, eccentric, and you really get them to contract, and you're having trouble again reproducing symptoms or getting them to improve with that kind of load, it's maybe because you have to add a speed component to it, right? So I don't know how you would necessarily, well, I guess you can get them to do it with just faster. If you're talking about the same exercise where you wrap a TheraBand around their ankle, get them to do dorsiflexion and inversion and resist it, and just get them to do it quickly. That might be the key to what to the rest of the remodeling. Because when you think about you're running, it's rapid contractions, right? It's not slow, steady contractions.
Yeah. I think the part that is harder to imagine is like that progression that we are not used to take the patient to the last stage. Yeah. And it's because that's not like our day-to-day, especially people that work more with spine and they don't have many sports experience. So I think that's challenged this last part of the treatment.
For sure. You don't have to do plyometrics a whole lot in the spine.
Yeah. So I'm just, that was the reason of my question, just curiosity. So do you have any suggestion that people could like look up to find more ideas of progressions and different types of loads?
Well, I've gotten a lot of my information from the diploma program, but then afterwards there are a lot of good researchers out there with regards to tendon rehab, which we would call contractile dysfunctions. So now just off the top of my head, Jill Cook, Silbernagel, Peter Maliaris. If you guys want, you can also go on the Mackenzie Institute International website, and there's a reference list there with all the studies pertaining to MDT, and I'm sure there's a lot of studies that have to do with contractile dysfunction as well. That's a subject that interests you, and it's divided into body parts, right? So extremity, lumbar, cervical, thoracic, and I think if you just Control F contractile dysfunction or tendinopathy, you'll find a lot of studies that have studied tendinopathies, but also within a MDT framework. So that's a good resource because they continuously update that.
Yeah. And then it's a good starting point just to read some material and find some ideas and suggestions of progression. That's great.
And on that website as well, I know that a lot of the times they get either faculty or volunteers like myself do a study review. So if you're lucky, I mean, someone already read it, is going to give you the take-home messages, and but I would also encourage you to read the study itself. Yeah,
that's a good idea. And my last questions about the arrangements now. So do you see any different combination of movements that usually reduce derangements and extremities? that are different from the standard that we learn on courses, or you see, usually on books and things?
Yeah. I think, typically you would learn about, active, passive, repeated movements in the courses. And I think it also depends on who's giving the courses and what they found to be effective as well, right? So, I mean, the only load that you would use more in the extremity more than in the spine would be resisted loading. You don't forget about sustained. Sometimes you need sustained loads in the extremity to reduce derangement, but you may also have to use resisted loading. And what I mean by that, and I find it to be more useful in the shoulders and in the knees. But what I mean by that is, if I get let's say you start with a shoulder derangement and you've had to do, I don't know, extension, and you've gotten 50, 60, 70% better with that, but then it starts to plateau. Extension, you try various ways and it doesn't further improve, right? And you're left with this end range flexion, abduction pain, and minimal loss, but it's still derangement. It's just you can't get to it by the way you started initially. And even if you try horizontal, hand behind back, you still can't reduce it. So what could be useful in that case is, let's say if you got a TheraBand, okay? You attach it, let's say if I'm sitting like this, the door's in back of me, you attach it to the door, close the door, and you pull on the TheraBand in such a way that it pulls your arm backwards, right? So it's passively bringing your arm into flexion, and from there you do extension, just about 20, 30 degrees. You don't have to go all the way down. You pull like this. It has to be a fairly large amount of resistance, right? They shouldn't be able to pull it all the way down. So pull, and then you slowly release it and allow the TheraBand to bring you back into end range flexion. So either that, or it'll also be done in abduction this way. And in the knee, for example, you can, let's say you got your table in front of you and you're using a TheraBand, you wrap it behind your knee, tie it around the table, the leg of the table, and you start pushing into extension like this with resistance.
Yeah.
So
final knee extension resisted.
Right, exactly. For some reason, when you contract the muscles, let me move here. When you contract the muscles, it adds this compression to the joint, which then helps the derangement reduce more efficiently than just passive or active repeated movements. So that's my hypothesis anyway.
Yeah, no, it's very nice to hear that, because I don't remember, I heard other therapies saying that, but I never learned formally. And I was just curious to ask you that, because sometimes it's hard to get the 100% and then you don't know what else to do. The person can do like extension completely and go all the way. I had like patients like that.
Yeah.
And sometimes you don't know how to reduce 100%, that derangement, that's right, but you can get it all. So it's just good to have these different insights to give us ideas of what to do next.
Yeah.
And think about these resistance movements that are helpful that I haven't previously learned. So so it's great. It's also a lot of good insights.
Don't forget about, again, plyometrics. It's not only used for contractile dysfunctions. All the movements that you can use in the extremity to reduce derangements, they can all be done ballistically, right? So if you, I don't know, say if you take shoulder extension, for example, then if you've done shoulder extension, over the table like this, and you've tried to add some resistance to that even, and you've done it 10 different ways and you can't figure it out, maybe what you need to do is just take the arm and swing it back. Same thing for the knee, same thing for other joints as well. Let's say you get into a position of hip extension, loaded hip extension, you reduce it to, I don't know, 60, 70%, and then you can't get any further. Well, you might have to mess around with the amount of internal, external rotation, but you may also have to, give it heaps. You know what I mean? So give it a really good push at the end.
Yeah. Yeah, no, that's very good to keep that in mind and remember that when you are treating, because sometimes you just go to the traditional and forget about these ballistic movements. And right. I mean, it's very common for thoracic. I remember everybody doing the rotations with the ballistic force, but for right. extremities, I don't think it's something that I've done before that I heard. Yeah. Like the same reasoning, it makes sense. It's just good to be reminded and have more options on the table to try when you see like, oh, I can reduce completely. So that's just good to know and keep that in mind.
Right. You also don't want to, it's not something that you're going to use on the first day, right? It's something that you would have done, hundreds of reps of repetitions before and realizing that, oh, this person needs more force.
More force. Yeah.
You try sustain and that doesn't get it, and then you know that they are able to handle a lot of load without injuring themselves, and that's when you would attempt to do ballistic movements.
Awesome.
Yeah.
So let's transition to the final question. So we already talked a little bit of resource of information, but other than the ones that you mentioned, do you have any other resources that you would like to share with us?
Yeah, sure. I have, I don't know if you've heard of the Mechanical Care Forum. I know it's a competing podcast, but it is something.
It's a very good resource.
That's right. It is something that actually helped me improve and it was nice to hear not just the MDT faculty and people in that world speak, but he also interviews other people that are outside of the faculty, outside of the McKenzie Institute, and it's interesting to hear their perspective as well. I learned a lot on that podcast. What else? I mean, personally, I found that when treating chronic pain, I know this is not the subject of today, but I felt like there was improvements on my part to be had with treating chronic pain syndrome, and I found it to be really interesting lately. Annie O'Connor and Melissa Kolsky's work. What's it called? The pain mechanism classification system. If you ever looked that up, it's helped me a lot treat my patients with chronic pain. It helped me subdivide them, subgroup them even more. Otherwise, what other good resources? We had mentioned the McKenzie Institute website, podcast. I mean, again, I'm in a fortunate position where I have I'm working with other diplomats, right? So whenever I do have a question, they're right here, or they're right next to me in the other room. So if you're interested in this system, I think there's really no better way of learning it than working in an MDT certified clinic where you have other certified or diploma clinicians that you can bounce questions off of, because this is not something that you can learn it on your own to a certain extent, but you're going to need someone who's gone through more patients and have seen a lot more cases to help you out with the ones that you have trouble with. So on top of that, well, I mean, diploma program, there's always that. I know it's not always possible for everyone to go through it.
Yeah, I wish we had more McKenzie certified clinics. That would be easier. Yeah, it would be great. Yeah. And what advice would you give to clinicians that are starting their careers?
I mean, I'm totally biased, but I mean, get your MDT training on. I honestly, because the first 2 years, like I said, I mean, I worked as a manual therapist, and I've taken manual therapy courses, which I barely, the skills I barely use anymore, because MDT simply makes more sense to me. I would tell them, if you, right now as it stands, MDT is the most researched system out there. And if you want to be evidence-based, then you'd go where the evidence takes you. That would be my advice. Totally biased, I'm aware, but it's what I feel like. It's
what's been working for you.
Yeah, absolutely.
And final question, what personal qualities or abilities that you think are important to become a successful physical therapist?
I've had my fair share of students, and university students, and I've realized, at least for me in the private clinic, in that kind of setting, you got to be a people person. If you, like, I would consider myself an introvert that has adapted to his work demands, but if you're uncomfortable talking with people, and if you are too much of an introvert, then it may not be the right field for you, because that's all you're doing. You're talking to people and you're seeing people all day, right? And to be a successful therapist, I mean, even before you get to your MDT skills or your manual skills, you have to build therapeutic alliance. The patient has to actually like you to spend half an hour with you repeatedly over the course of a few weeks, right? So you got to have that, and that's something that I don't think you can really teach. It's something that people might. I mean, like I said, I am an introvert, but I think I've adapted to the demands of my work, and at this point, I'm comfortable talking with anybody. It's just if you're not, then you might have trouble getting patient buy-in. They might not trust you as much. If they don't like you, then already there, the literature shows that they don't like you, don't trust you, you're not going to get a good outcome. So I would think that'd be number one, because everything else you can learn, right?
Yeah. The patient needs to feel the empathy, and then to buy the treatment and really do what they have to do to get better.
Yeah, and I mean, maybe one more thing is, I've realized, and this is to me listening to Trevor Noah's what's it called, an ebook, and he describes these situations where he's from South Africa, and he has learned many different dialects, and he found that it has gotten him out of situations where it could have been, there could have been a fight, for example. Now, it's nothing like that with me in the clinic. It's just, I realized when you talked about, because I live in Montreal, where it's bilingual, English, French. And when you speak to people in the language that they prefer, they tend to open up more. It's almost like language has this crosses barriers that they don't see anymore. So they have a feeling they're talking with someone who understands them more, and so they just open up better. And if I've had these students that were not strong, whether in English or in French, and the conversation just is not as smooth. They're going to get the information that they need, but they won't necessarily get as much, build as much rapport with the patients. So language has been something that's helped me a lot. Being bilingual.
Yeah.
Less of a problem in the States because everybody speaks English, but just as a side note.
Spanish.
That's would
be good to know Spanish.
For sure. Yeah.
I think people feel more comfortable talking on their, I don't know, mother tongue or
For sure.
The one that they grow up and feel more comfortable.
Yeah.
I would in Portuguese.
Yeah, that's right. It's already hard to explain as it is, and if they have to do it in a second language.
Yeah. To connect better with the patient.
Sure.
So Duc, if people want to learn more about you or your work or contact you, how they can find you?
Oh, well, you can just email me. Duc, DUC, physio, PHYSIO @gmail.com.
Okay, great. And just for the ones that were listening to us, if they want to see what Duc was doing on the video, showing the movements with the resistant band and the knee, you're going to have the video on YouTube and our social media, so you can just check it out, just to remind you that. Duc, thank you so much for taking the time to talk to me today. I learned a lot of different insights about extremities that I think are going to be very helpful. Very practical tips. So that's one of the goals that I wanted, to help people to have more options and think about practical ways of improving our treatment. So I really appreciate it, you taking the time.
Sure, my pleasure. Thanks for having me.